Welcome back to HealthTech for Patients, edition number 3. We're getting lots of very strong and exciting feedback. Please keep sharing your ideas and giving us your take on the event through the chat and, of course, through the survey. We now have our second distinguished panel of speakers ready to open our roundtable on cardiac diseases. And please remember, if you want to ask questions, and we're sure you want to ask questions, please do so, and the questions will be transferred to the panel, and they will be answering and discussing your ideas at the end of this roundtable. It's my pleasure now to hand over to our moderator, to Anaïs Le Corvec. Anaïs.
Thank you very much, Alison. So very happy to be here to moderate this panel. Just for those who don't know me, I'm Anaïs Le Corvec, so I manage a wonderful association of cluster in life science, so really in touch with companies, research and innovation across Europe. It's called CEBR, and I also have my own company in social innovation, where we actually measure the impact and the social impact generated in many applications related to health. So I'm really happy to be here. I have an amazing panel with me, so I promise I will not talk long. And what we've asked the panelists is to present what they do. So we're talking about cardiac diseases and really how to enhance the care of patients. So each will have 5-6 minutes. I will be a little harsh on the time, but that means that way we can really have a nice discussion afterwards. So with no further ado, I will start to introduce our first speaker, Dr. Jean-Philippe Verhoye. He's the Chief Department of Thoracic and Cardiovascular Surgery at University Hospital Rennes 1. Thank you.
Good afternoon. It's a real pleasure to be here this afternoon, and I would like first to thank our president, Marie-Von Niance, for the invitation to share with you the specificity of my specialty of cardiac surgeon in order to take care of the patient and news of this kind of caring for the patients. What is a cardiac surgeon? A cardiac surgeon is a cardiologist with a knife. So it's, again, a trauma, a sophisticated trauma to operate on a patient. A sophisticated, yes, but a trauma. And again, I think now the new generation of surgeon and cardiac surgeon have to take care about the patient and develop a new consideration and a new relationship with the patient as a patient like a partner. And for the operation, I think I have to be a kind of coach, and I have to have a lot of exchange with my patient. And because cardiac surgery is a kind of trauma, I think we have to prepare the patient to the operation, like you have to prepare a sportsman to the operation. The new concept is not to say to the patient, you leave your home and you go directly to the operating room. No, you have a disease and you have to be prepared to be operate on of your heart. So there is a lot of innovation in technology for cardiac surgery, robots, computing-assisted surgery, but there is, again, we need new concept of relationship with the patient around all that technology. So we can try to put in place the new concept of preparation of the patient in order to have an active rehabilitation after the operation. So now, because or thanks to the technology, it's possible in your home, at home, to prepare the patient with some very subtle exercise before the operation, respiration exercise, cardiac exercise, in order to have a better results during the intensive care unit and the hospitalization after the operation. So I think the topic for this afternoon, for my opinion, in my case of cardiac surgeon, and I will be very happy to discuss with the panel and with you, everybody, about the different questions that we can have in that topic. Thank you.
Thank you very much for this short but very straightforward introduction. With no further ado, I'll pass to our next speaker, Magdalena Daccord. She's online with us today. She's the Chief Executive of FH Europe. Magdalena, the floor is yours. As I said to the other, you have about 5-6 minutes to just introduce us to what you do.
Absolutely. Thank you so much. It is an honor and a privilege to be with you, even though I am joining online. And just on the contrary to the previous speaker, we represent a patient community and as well citizen or people living with inherited lipid conditions. And among them, the most common genetic CVD risk factors like familial hypercholesterolemia, its rare and severe form, as well as elevated Lp(a). FH Europe is a network of patient organizations across wider Europe. We have 32 organizations in 28 countries, but progressively we are as well including individuals who want to be part of a, what I would say, movement towards changing how we talk about cardiovascular diseases and patients towards cardiovascular health and citizens. We do collaborate with societies like the European Atherosclerosis Society and the Global Registry, as well as other policy making and advocacy organizations like the World Heart Federation and newly formed European Alliance for Cardiovascular Health. So as you can already hear, there's a lot around health, around promotion and prevention, so that we can really find ways that nobody with an inherited CVD risk factors becomes a CVD patient. I actually don't need all the 5 minutes to introduce our community, but I just wanted to say how much I appreciate the first panel and really very articulated people, especially patient advocates, and I hope that I will be able to build on some of those empowering and encouraging statements in this panel. Thank you once again for having us.
Thank you very much. So you're all following the time. This is good. This does not happen all the time in most of the panels, so I'm very happy. Laurence, Comte-Arassus, you're the general manager for the FBFA zone. I'm sure you're going to tell us where that is, but I would say Europe, Africa, most likely, at G Healthcare. So we heard a doctor, we heard a patient, and now we hear a company. So what do you do, and what can you tell us about it?
Thank you. So first, good afternoon to all of you. It's really an honor to be with you because, yes, I am a company, I will say a representative, General Electric Healthcare, but first I am a health woman. I'm working in medical device for more than 30 years, and when I was 16, you will never believe, but I wanted to be surgeon in Africa. So certainly a reason why Jean-Philippe is someone that I know for a long time, and he was, I think, suggested my name to be present with you. And it's an honor because when every day I wake up, I really think to the patients, because why I do this job is not to do money, is not to, we say, do some PowerPoint or to work with Excel, but it's to really bring innovation to the patient. And it was, I will say, all my life, from my first day after school until now, and I'm sure it will be the case until the end. So General Electric Healthcare, I am working for this company for now more than 2.5 years. It's a company, of course, it's a US company, and certainly you know GE, but few people know General Electric Healthcare. We are, of course, selling some and producing some equipment like CT, like MRI, like ultrasound, like ventilators that we were using a lot during the COVID period, or anesthesia. So it's from small, medium, and really big, I would say, equipment, even go to the cyclotron. We are working in 3 main areas, so of course cardiology, but also oncology or neurology. I quite very proud to work for this company in France, because we are the biggest, in fact, medical device in France, with more than 2,800 people that serving you, patients, every day, and of course our doctors. We are an independent company now from January 1st, and with now a new mission, which is create a world where healthcare has no limit. And this no limits, it's for you, for the patients. All our employees, in fact, are working to bring innovation to hospital, to private centers, so to our doctor, to be sure, in fact, that in your everyday pathway, in fact, when you are in one of these centers, we will be able to treat you the best way, and to be sure that we could transform, in fact, this experience, what, in fact, Jean-Philippe just said at the beginning. And what can I say? It's every day. We are thinking the product when we are in research and development to be sure that we will bring some progress to, of course, to our, I will say, existing product, but also to new product, to be in capacity, in fact, to treat you with all the new materials. In cardiology specifically, so in the past, for example, we could have some stent, after we had some TAVIs, and for us, we are really building, thinking all the equipment where we will be sure to treat more patients and to bring quality, in fact, to the additional year of life, as we say. This is the reason why we are working in what we are calling the precision medicine, to be sure that we can treat, I will say, the good patient at the good moment in the good place. And it's, I will say, a chance to work in this company because we are clearly in between you, the patients, and the doctors. And as I am working for a long time in this environment, I was working and I was certainly one of the first person in France to say we need to work with patient association, in fact. A long time ago in France was very difficult to bring, for example, defibrillators in France when I was working for my previous company. And I was one of these persons who fight to have the reimbursement for these defibrillators, and we obtained in France after quite a lot of country after, so more than 12 years ago, and it was due to patient association that we succeed to bring this product to, I will say, all the patients who need this product. So I think I will be very happy to exchange on this topic, this cardiology. I passed more than 25 years directly in cardiology. It's like a passion for me, and I really like, of course, this environment, and it's a pleasure to continue the discussion after.
Thank you very much, Laurence. So with no further ado, I'll pass to the next. So Elie, you're Elie Lobel, you're the next speaker. You're the CEO of RDS, Rhythm Diagnostic Systems. So you're going to demonstrate some things to us now.
So yeah, thank you very much. I'm very happy to be here with you this afternoon and to share with you what we are doing at RDS. So I'm Elie Lobel. I'm an engineer and a medical doctor, and I am the manager of RDS, which is a young startup company based in Strasbourg. We are inside the hospital in Strasbourg, in close contact with the patients and with the healthcare professionals. And we are developing a very special solution, a miniaturized solution for remote monitoring of cardiac and respiratory parameters of patients. And the issue we are trying to take care of is to improve the management of patients after surgery, especially after major surgeries. And what is the problem with major surgeries? The problem is that there is a risk, particularly in the first week after the surgery, of complications. You have approximately 15 to 16% of patients who are undergoing an elective major surgery who will have a complication in the first week after the surgery. So what happens is that because of that, surgeons prefer to keep the patient in the hospital after the surgery to monitor them, and the patients will stay several days, usually a week, after the surgery in the hospital. And we think this is not an optimal solution. It's not so good for the patient to stay in the hospital so long. There are various risks of nosocomial infections. Patients don't sleep well in the hospital, you don't eat well in the hospital, you are not very active in the hospital. So it's better if you can leave the hospital sooner. The problem is, how can you be monitored for your cardiac and respiratory key parameters outside of the hospital? So this is where we are bringing a solution, because in the hospital, this is done with these big monitoring devices, which usually, weight like 12 kilos, 15 kilos. And so we have developed a very miniaturized solution. So I can show it if you allow me. So it's based on this very miniaturized patch, which is an electronic marvel. Actually, it's full of miniaturized electronics with 5 sensors. And you just put this small device on the back of the patient. So very simple to install. And then, thanks to that, it's connected. It is sending the data to a secured cloud where the data is analyzed continuously. So thanks to this small device, it's possible to monitor the key cardiac and respiratory parameters of the patient outside of the hospital, as if the patient were still in the hospital. So this is really interesting because this is opening new options for clinicians on how to take care of these patients after surgery. And the idea is to make it easier for surgeons to decide that patients can go back home earlier and be monitored with the medical team of the hospital, thanks to this device, continuously for several days. So, of course, this is a solution which is thought to be very simple to install by the clinical team in the hospital before the patient is going to go back home, but also something which is very important. It has to be well accepted by the patients when they are home, because, of course, they will be wearing this device. So we have been very careful about trying to make sure that this is very simple and comfortable for the patient. And the nice thing about it is that you have to trust me, I have worn it several times, but you really forget it because it's so small, it's flexible. You keep it when you sleep, you keep it under the shower, so you keep it all day long for a week, and you really forget it, and you can sleep with it. It doesn't prevent you, it's not bothering. And I think this is something very important because it has to be simple, it has to be comfortable, all the more as that the patients which are going to use this device can be patients which can be patients of major surgeries, so very often patients who are 60, 70, 80 years old. So, we don't expect them to have to press any button or do anything complicated. They have to concentrate on recovery after surgery, which is, something, it's a major event. It's a traumatic event. I think this is what you mentioned. A surgery is a very traumatic event. So you need to be able to concentrate on your well-being, on your recovery, on getting more activity. And so this is really the idea that we are pursuing with this solution.
Super. Thank you very much. And just on time, too. Next to speak is Céline. Céline Desvignes. You're the patient-centered outcome specialist at Mapi Research Trust. So let us know, and you have some presentation for us.
Yes. Thank you. Thank you for having me. It's a very great opportunity for me to talk about patient-centered outcome. I've been working for Mapi Research Trust for 8 years now. I will briefly present the missions and the service of Mapi at the end of this speech, but first I wanted to present one way, or to introduce one way to better take care of patients. At MRT, we think that one way to take care of patient is to get the patient experience heard, valued, assessed, and on what matters for the patients. And my speech will be around why it's important and how we can assess patient experience. So when you assess patient experience, the first, and it has been already presented by my co-speakers there, that it really improves patient and clinician communication. The patient better understand their disease, and the decision-making process is also better shared between the patient and the clinician. It's also an occasion to monitor treatment or monitor the clinical practice, and also to provide some adjustment on the treatment itself or on the clinical practice. It's a kind of real-time tracking of treatment effect or practice. And the last point, but not the least, is what we call patient activation. I'm pretty sure that you all know what it means, but it's when the patients can advocate for themselves. They know their disease. They know how to take care of themselves. And when you reach this point, the patient feel more motivated. We were talking just before me, I was talking about the burden of long-term, how to avoid this feeling of being overwhelmed by the disease. So I think as soon as you assess this experience, you can try to maintain the patient motivation high, and then it can lead to patient empowerment of their own healthcare. So how can we turn this patient experience into meaningful and comparable data, because it's what we want, how we can turn subjectivity into data that can literally trigger change and can be shared at the European Commission, for example. So one of the possibilities to use what we call patient-reported outcome measures, maybe some of you know that, but it's questionnaires, it's subjective report of patient health status. And second part, very important, coming directly from the patient without any intervention of assessment of a clinician or someone else. It can lead to two types of assessments. We already talked of this, so assessment of the treatment or an intervention like the surgery, efficacy. It could be like physical, the ability of walking after surgery, physical functioning, emotional functioning, we're talking about mental health, emotional functioning, social functioning, my ability to work after a certain intervention. The other aspect that now it's more and more important is to assess the quality of care. So the concepts are a bit different. We're talking about long-term efficacy, so treatment burden, treatment adherence, could be communication with healthcare professionals. So those measures, those questionnaires, are usually administered in the clinical settings. We know that there are barriers of using such questionnaires. That's why it's so important to select the appropriate questionnaires, because there are so many out there. So there is a very first important step is to select the appropriate questionnaires. And this questionnaire, these prompts, has to be easy first to administer. Easy to score. As soon as you get a score, you can have an interpretation, meaning like a diagnosis quite quickly. This questionnaire needs to be accepted by both the clinician and the patient and not interrupt the clinical workflow. I think this is also a major criteria as well. Over the year, we have seen that now the questionnaire not only administered at the hospital, but also at home. There are many advantages of that, but I will just highlight two of them. The first one is these prompts, when they are completed at home, they allow better health equity because you can reach a more diverse group of patients and you can reach vulnerable people that are not always allowed to travel, or they just can't travel to hospital. And the second aspect is also the assessment of stigmatized symptoms, like we were talking about mental health, but also sexuality, also other aspects that the patient, they are not really keen on sharing with the clinician for many reasons. And here, I think the support of technology could really help to promote the use of these questionnaires and therefore help the follow-up of a better care for patients. And for our field, what it means, technology, it's meant to turn the old-fashioned paper questionnaire into electronic versions, right? And we all know that there is an endless list of benefit of that. So here I just listed some of them, which is like increase the completion rate, decrease the data entry error, less burden for the patient. So we were talking about traveling. They do not need to travel to get their questionnaire administered. Someone in the round table 1 mentioned the gamification, which is a way to administer questionnaire in a more funny, interactive way. So this way we are collecting more data. And it also allows to have some prompts alerts, like if there is some scores that could be too high, then it's connected to the clinician, and then you can alert the clinician on a special status. There are also obviously some consideration linked to the tech, so data security, the access to technology and literacy, the usability of device, and also to make sure the equivalence between the paper and the electronic version. So in all of that, Our non-profit organization has the mission to facilitate the access of such questionnaires, and with a broad range of service. The first one, very important one, is to develop or to identify the appropriate questionnaires for the specific condition of use, to distribute some questionnaires, to translate them, and also to convert them into electronic version. So I will be happy really to discuss this amazing tool. I think that really could help in patient healthcare.
Thank you very much. Last but not least, Vincent Poher, CEO of AVALUN, part of BIOSYNEX Group. Tell us.
So first, thank you very much to be here today. So as you said, I'm the CEO of a French company called AVALUN that is based in Grenoble, and that is part of the BIOSYNEX Group, which is also a French company based in Strasbourg. Basically, my company developed a portable and connected mini lab, which is called LabPad, which is a point-of-care device that has something unique. It can do coagulation assays and immunoassays on the same device. So you just need one assay, a range of small macrocuvette, and a very small blood sample from a finger prick, for instance. So the assays that are available on this device are INR to monitor people on warfarin, CRP to measure inflammation status of the patient, and D-dimer, which is a test to exclude deep vein thrombosis and embolism in general. And other tests are under development. So it's a very nice, very easy to use device. But from day one, in my company, we really focused on patient pathway because the idea is to change people's life. And how do you change people's life is not through a technology or a new point-of-care device. Is really to bring the right tests at the right time together with the right healthcare professionals. So we really need to work on a country-by-country basis because patient pathways are completely different from one country to the other. And then we need to gather everybody around the patient in order to bring the right solution. So as a very concrete example, we've done something quite unique in France where we got a reimbursement to monitor people on warfarin. And you have to know that France is not a very good country for point of care because the patient pathway for biology is really based on biological labs. Okay, so we worked together with the biologist, and we decided to help them to structure the patient pathway in the primary care. So they buy our machine, they do all the qualification and so on. So they are sure 100% it gives a good result. That's a quality insurance, let's say. And then they equip other healthcare professionals like nurses to go to the patient to perform the measurement. So, for instance, a nurse can go to the patient home to perform the measurement and to take care about hemorrhagic risk, for instance. They can go to nursing homes. It works very well also in dialysis centers. And basically, by doing so, we can combine both quality and very easy way, very smooth patient pathway. And the idea was really to, for all these healthcare professionals collaborating together, to go to the patient. So either physically to sample the patient, or digitally as a remote expert, if there is something to be. If there is an expertise to be brought at the point of care. So right now we are monitoring 1,500 patients. It's a big experiment in France, and we are working towards trying to change a bit the French system. So that's just for INR, but it can apply to many different biomarkers. And every time we really need to have a holistic view of patient pathway and to say what is best trying not to break what is working, but just to bring something new and to bring easier patient pathway for a better outcome. Thank you very much.
Thank you very much. And thanks to the 6 of you for really keeping up the time so we can have a very nice discussion. So I have plenty of questions, but now I'm going to surprise you a little bit. No, because if not, it's not prepared. I didn't share.
You're going to dance?
Yeah, maybe. So my first question would be, because you mentioned patient pathway, and I think patient engagement in the last few years has really improved, and I hope Magdalena will agree on that. It improved, at least it's part of the political journey. It's there. That doesn't mean that it is implemented right away. But I would like to know, because we have everybody, let's say, in the pathway or in the value chain around the table. So I would like to ask you, how do you see the engagement of patient? What is missing, or what would you be wishing for, let's say, in cardiology in particular? Maybe I can start with you, doctor. What do we need to engage better the patient?
I think it's a question of education, and the problem is not to discover your body when you are a patient, but you have to discover your body when you are a student. And the problem all over the world is that you have a big engineer that they know how to calculate everything, to financial everything, but they don't know where there is their, I don't know, excuse me, the liver, or your liver, is it in right, is it in left? Do you know where is some other organs, you know? And sometimes, quickly, you're in the front of a doctors. We try to do a very big lessons of physiology, pathology, and mental risk. So the first things is to restart the machine and try to start at school. And first, you have to know what is a body, and what will be very interesting, what is your body and how is functioning. And after, we can try to redo the world. But now, I think the first time is here. And probably it's really possible, like some emission like that, to discuss about that and sensibilize the politicians to that and the educationer to that. I think it's very important.
Thank you. Laurence, what do you want to say?
So first, I fully agree with you. Second point, I will take the company point. Most of the time, a lot of people is asking me, are you not afraid to speak due to the fact that you are working for a company, for industrial, and are you sure that you can? Because you are not a doctor, you are not a patient. I think we are all health actors. And I'm really convinced for the beginning that we have all a part to do in our pathway, in our life. I was working a lot on prompts in my past life, and I'm also really convinced that it's a tool that we need. So to come back on the point of Jean-François, we need to be sure that, of course, we have a strong patient association, and there is a lot, and I know that a lot of people are hearing us. But not only, in fact. To be convinced that to be a patient, we are responsible, and we need to be aware of all, I will say, the ecosystem. Also, I will say from the equipment side, medical side, pharma side, and really try to understand and to be part of this ecosystem, and not to consider that we can work alone in the patient association, but that we need to work together. And I think this is the reason why I think we are all representing here. Because health was not really in the center of our, I would say, politics ecosystem, and it's not only the case, in fact, in France, but all around the world. And at the beginning, you were asking me what is the FBFA, so this is France, Belgium, Luxembourg, and all the countries of Africa who are speaking French. And I see the same thing everywhere in every countries, in fact. So we really need to be sure that we are working together. We need patients, for example, when we are building our innovation. So include also patients from the beginning for the first idea, and not leave the engineer to work alone or to work only for the doctors, but really also work with the company. When we are making, for example, equipment and we are thinking innovation, if I take an example, we will think, for example, in some specific equipment, how we can be sure that we will reduce, for example, the radiation, which is absolutely key on the long terms. So of course, when we are treating patients, it's very important for a doctor to treat more patients, but we also need to be sure that we will have this security point, for example. So the 2 points that you name, but also the security. So it's a lot.
It's a lot, but it's very interesting. At least, Magdalena, I will keep you last because it's a very patient-related question. So if you don't mind, I'll go around and then you can close on that question. Great. Céline, what do you want to say? Because I'm sorry, I have to make the comment. From what you presented, I have my only question is, okay, and how is the patient informed of the outcome of this? How do we engage the patient also in the research and so they see the results?
Yeah, thank you for the question, because I think it's a critical point that where technology can help, because the more you ask the patient to be involved, the better you have also to share back the data to keep the engagement alive. So it's also an important question, how we share the data back to the patient, in which way to have very visualization tool, data that are easy to understand, that are true, that are really reflecting their outcomes. And this is really where technology can help. And there are many works that is done on, we're talking about gamification and just tools that really help to synthesize the data. And this is the hot topic today, I would say, in the electronic version of questionnaires. Mm-hmm. It's really beyond just developing electronic questionnaire. It's more how you report the data, how you share it with the patient. And it means that if you share it with the patient, it means that you value the fact that these data should be shared with the patient and not only with the doctor, because usually the data just go back to the doctor, then you talk with your doctor, and that's all. Here, the patient is really part of the loop. So I think it's really important to work on the deliverable, but also just the fact to involve the patient in the sharing of the data. It helps with the transparency, and maybe also it will regain the trust of all the stakeholders, including the pharma company that was mentioned at the roundtable 1 as well. I think it also helped to have transparency on the data sharing.
Thank you very much. Vincent, your take.
So my background is I am an engineer, but I would say technology is just a means for an end. And what is really missing to me is somebody who is actually coordinating the patient pathway. Who is actually coordinating the patient pathway? And there is a big inequality is whether you've got a doctor in your family or not right now. I'm from a family where there are plenty of doctors, and so it's very easy to have somebody at your side saying you should go and see this person, this doctor, and not this person. This guy is not worth anything, which is something usually that nobody says. But really, there are good doctors, and there are no. And who is making sure, for instance, that your patient pathway is smooth, you get the result in time, and that as a patient you're going to the next step. And basically, we will find many technological bits around that can help for every stage, but the big missing bit is the patient pathway coordinator to me.
Okay, thank you very much. Elie.
So thank you for this question, because this is for us really a major concern, considering the fact that this is a solution to help patients go back home after a major surgery. So the remote monitoring solution is installed at the hospital before the patient is going to go back home, but then the patient is going back home with the solution, and there is no doctor, no nurse at the side of the patient to make sure everything is okay. So we have to make sure that the solution is working very simply, very intuitively, and that it's very comfortable for the patient. And so we are paying a lot of attention in making sure that the solution is simple. And what we are doing with the solution is we are providing patient relationship management, which is a call center, which is calling the patient when the patient is going back home to make sure the patient has understood how this is working. Because we also know that the nurse who has installed this solution to the patient before in the hospital was supposed to explain, but we also know that she doesn't really have the time. She has many other things to do. So we are making sure and calling the patient when the patient is going back home to explain again the simple rules of how to use this device. And just to give you an example, the patient can keep it all time on him or her. It's also when taking a shower.
Yeah.
So we have to explain to the patient that if the patient is taking a shower, then you don't have to remove it. You can keep it. And then there is another rule. You can put it under the shower, but you cannot take a bath with it because it has to stay in the open air. So we explain all this very precisely. And also the second thing which is important is at the end of the week of monitoring, we call again the patient to tell the patient, okay, now everything is okay, you can remove the device, so the patient can do it with some help at home. And then to put it back in the box, because this box then is sent back to us and we clean it, we refurbish it, and it can be used later on for another patient. So, and what's very interesting is in all the clinical trials we have run, we are always asking the patient the same question, which is, if in the future you would have to go to the hospital again and you would be offered the possibility of going back home earlier with this solution, would you accept or would you refuse? And 95% of patients say they would accept.
Very good. So, patient association is on board. Magdalena, what do you think? Let us know.
My goodness, I think that the time I saved during introduction, I will double now in trying to contribute from our perspective. First and foremost, I would like to thank all the others who have contributed. I think there were a lot of points, so I will just reiterate or reinforce some of the points made by Céline, for example. Great point on data sharing with patients, back to patient, because that really creates trust and is an evidence that their contribution has been taken on board and implemented. That's sort of quickly to build on this. And I really like this reference to technology as a means to an end. It can probably help overcome some of the logistical barriers in reaching out to a lot more people at their time preference in their safe space. But I would like to maybe articulate some of the fundamental points. So from the perspective of FH Europe as an umbrella patient organization, but also learning from other peers in the area, I think we need to start from the fundamental point. Nobody, but nobody, unless something new is out there and I don't know about it, chooses or wants to be a patient in the first place. And that's already a starting point where our engagement becomes difficult because and I probably can say I used to work for pharma, I used to work for regulators. So it is in our daily job description. We want to do something for patient or engage patient. We've been educated, we were given the means. An individual didn't choose or didn't want to. So that's to start with. So their level of health literacy is far different, very often, than everyone else in the ecosystem. And there's the health literacy as me personally, as an individual and my health versus the bigger scope of how health and health delivery, healthcare functions. So there's already your first inequality and a barrier to engage patient in the discussion and contributions. And now over the past years, I've been trying to engage our community, and I would like to just maybe remind everyone that we talk about people who have genetic predisposition, genetic inherited lipid conditions. So there's already, to start off, a huge level of discrimination and stigma and misunderstanding. Now, we talk about disease that's invisible, and it's not necessarily disabilitating like other conditions. So that means that your engagement is different because maybe you don't see it, you don't necessarily suffer from it on a day-to-day basis up until something really terrible happens. So in order to engage someone, especially in cardiovascular diseases, you need to, in my opinion, demonstrate evidence that their voice and contribution matters. It's not enough to engage someone and ask them to contribute and say, hey, what do you think? It's actually actioning the suggestions that demonstrate evidence and the success. And again, it's easier to engage people when there is success. Yes, we have changed the policy. Yes, we have affected the clinical trial design so it's more patient-friendly. Yes, you have heard us when your device is actually able to carry in the shower or in your pocket and nobody sees it and discriminates against you because it's easy to pick up that something is a little bit off with you. And then change the perception of the patient. The moment you have the label patient, you already start from a different point. We've discussed that. But we are talking about the pharma or medtech industry. And very often, ladies and gentlemen, let's be honest and transparent, it was a prerequisite to engage patient in terms of better development, reimbursement, access, and so on and so forth. But there is one very important stakeholder that we kind of mention, but maybe not sufficiently enough. And that is your healthcare professionals, your doctors. Whenever we go to congresses, we very often hear, you know, patient this, patient that, but they are not involved in guidelines development, consensus papers. So their voice is already being missed, not to say dismissed. And so I think we need to as well work a little bit as a community to reestablish or establish patient perception as an expert within that community and value the input from patients. And then once we have them committed, and I'm just about to finish, is to say that they operate in a safe space. Mm-hmm. Safe space is everything from the time, the language, the respect. So no longer the tick box exercise, but reflecting on that those people have lives. Very often they different age. It's, you know, we use this term patient, but there can be a female, a male, older, younger, pediatric. Mm-hmm. We need to employ different tools. Just like in marketing and sales, we have targeting different groups. We need to do the same here. Age, sex, time availability, level of interest, and help. Probably this will be my last point here. Individual patients can contribute on their personal individual experience. Yeah. However, we need to empower patient umbrella organizations and patient communities to help leverage a collective voice sometimes. It's important to have individual voice, but it's also important to recognize the collective voice of a group of patient experts. So I've jotted plenty of bullet points, but I think I could speak almost for an hour, so I will give you the voice back, Céline.
Thank you very much. And you know, we're all in front of you listening because of the studio, so we're all very quiet. That's why I did not want to interrupt. But you're right, we have limited time, so I wanted to go for just a second round of questions. Then please, if you're online, you have specific questions, send them now, so we can have a little bit at the end to ask those questions. My second point would be, maybe I can start the other way around, but about technology, because we're in health tech. for patients. So I just wanted to make sure, for me, patient first. So we started with this question. Second is, okay, there's all this buzz. I'm not saying anything new about AI, about ChatGPT. Are we going to solve the world with just, putting a few things? I'm really interested. We have virtual reality. There are many things happening, obviously, technologically speaking. But I would like to know, where do you see the advances in this concrete field of cardiology? Do you see really a big change? Do you think, so what is coming up for those people listening to us? Also, I think it can be interesting, and you're all from your different viewpoints. I know it's a very broad question. We could be talking all afternoon, but maybe try your thoughts about what's coming up. So Elie, I will come to you first.
So I think we are a technology company, and we have to be very humble, because what we are trying to do is to provide adapted solutions to clinical problems, real-world problems, patients' problems, healthcare professional problems, and of course we are trying to do that with state-of-the-art technology, if it makes sense. And as you were saying, it's a tool towards improving the patient's pathway. In our case, what I would say, which is really something important, is trying to make the move towards, so to speak, less hospitals. So, really keep the patient in hospital as little as possible, and keep the hospital where it's absolutely needed, where you need to do some very sophisticated surgeries, or very sophisticated pathways that really need a lot of expertise, and maybe also a lot of technologies to support this expertise, but try to make it as short as possible. And from that perspective, I would say, and this is something, this is just a story, when we created the company RDS, we created it in February 2020, so it means like 3 weeks before, the world shut down. So I was like, wow, that's
perfect moment.
That's not a very good timing, And actually it was the other way around, because of all this COVID, people had to suddenly really rethink the way things were happening, and suddenly people realized that some patients need surgery, and even during the COVID time, but then you were trying to keep them as little as possible in the hospital, because you were afraid they would get COVID in the hospital, even if they're coming for other health issues. So suddenly people started to think other ways, and there was a real interest for, I would say, telemedicine in general. Whether it's teleconsultation or remote patient monitoring in our case. So for our case, we drew a lot of attention during that time. So it was good for us, because we had a lot of support, financial support, to develop the solution. But I think in the end, even of course if this was a very difficult time, I think it helped us learn some lessons. And now we are trying to implement these lessons in the real environment of the hospital and the patient's pathways.
Super, thank you very much.
So I'm more into biology, which is quite important though, because biological measurements are involved in something like 70% of the care of the patient, which is very important for patient pathways. And in biology, you've got new biomarkers coming up, and you've got new systems that are more and more sensitive. This is how, for instance, you can measure very little amount of troponin when you do a heart attack, for instance, and now all the protocols and patient pathway are evolving with new technologies as well. But at the same time, they are very, very old biomarkers, but the way you measure these biomarkers can completely change people's life. For instance, in diabetes, the continuous monitoring of glucose, for instance, even with a feedback loop with an artificial intelligence to inject the right amount of drug, is absolutely breakthrough, and it changes people's life very concretely. So that can actually happen in biology in different field. And there is a lot of technological development to be taken. Really.
Thank you, Céline.
I think I will just have a quick point on patient burden. I think it's very important to, we can see that patients have to deal on a daily basis with their disease, with their treatment. Now they are going to complete questionnaires, maybe 3 times a day. Okay, wow. Technology can help to have a better experience, to get better outcome, more accurate outcome. But we need to keep in mind the patient and to make as much as possible effort to lower the burden, because otherwise we can just go on the other side, say, oh, that's amazing, we have so many questionnaire, electronic version, that's great, but okay, does it really provide a better way to support the care, or does it increase the burden of the patient? Because now we can see also digital health technology where they are going to wear a watch to measure different things, then they go to hospital, then they complete questionnaires, and in the end they are doing many things to get outcomes. So I think technology can definitely support, as soon as the main objective is really to measure what we intend to measure, what to matters to patient, and that we do not increase the burden.
Thank you very much. Laurence.
I think a little bit of all of this. For me, it will be, don't be afraid by the future. We are living in a very difficult world, and COVID was, I think, a very difficult situation for all of us. For us, officially, I will say, we are selling equipment, but it's far away, in fact. It's also all this data, in fact, that we have from all our technology, but for all the information that we could have for the patient, all the information that we could have from the doctors. So it's how altogether we can be sure that we will really reinvent all this pathway from the beginning. So also the food, for example, we could have someone, I think, who could speak about how we are eating, what we are eating, and in the end, how we follow who we are, our disease. And personally, I'm very optimistic by life, and I think we are speaking a lot about technology, but it's more on innovation. And innovation could be in technology, how we are organized, how we are eating, but this is in our hand, in fact. We can say the world where we are is crazy, or we can say all together we will change, we will transform what we need to have a better future. So it will be perhaps my message.
Thank you very much. Very positive one. Please.
So I try to be positive too.
Yes, now you have the pressure.
and I'm sure that it's the way to be positive. The question is just how to keep medical humanity in the future medicine. And of course, we have to work together around that, because the engineer put humanity, the biologists put humanity, the doctors, the company put humanity. I think there is a new worker around. You say in France we speak a lot about the end of life and the new work around the assistance and the new worker of assistance for the end of life. But here we are just in a short sequence in our life where we are patient, because we will be patient. And during that only very small sequence, we have to keep humanity. And I understand the patient and the association of the patient. The work of the doctors is to understand the evolution and the disruption of the evolution, because we have evolution, but the disruption is that we don't have any evaluation. And the problem of our generation is that we have evolution without evaluation. And humanity is probably the short times, and it's the union between and during the rupture. If we don't have time to explain why it's evolving really rapidly, we need to have, and we have to have time to say, okay, we try to explain you why, because it's really evaluate really rapidly. And that time is humanity. When the doctor don't understand what is the new treatment, he have to keep time to say, okay, I try to explain you, and we will take, during that time, in January, evolve, okay? And after, we can take another step and continue. So, again, the doctor have to understand the evolution and have to keep humanity, medical humanity.
Thank you very much. Magdalena, do you want to add on the technology take?
Absolutely, yes. And it's a complex question and far more complex answers. And again, I really like when the panelists mention the responsible use of technology and making it human and evaluating. So it needs to serve a specific purpose. It needs to be there to make things easier, better, without obstructing. Ultimately, again, nobody wants to be a patient, nobody chooses to be patient, and they want to continue with their life as best as they can. But I also appreciate the intervention made that it's not just technology, it's the innovation, and innovation in sometimes in the way we think and the way we act, the way we collaborate. Sometimes it's not developing yet another tool, yet another app, yet another medication, but making sure that what we have in place is well implemented, evaluated. So from bench to bed and back to bench, I think that this for me is extremely important. Few examples where we see in inherited lipids and genetic dyslipidemias, the use of technology which advances our mission is the implementation of electronic health records and reading and detecting people who were missed in the process in the system. That's really fantastic. If we can fix the mistakes that human eye or human processes have missed out on, this is already great. And a lot of countries, interestingly enough, those sort of very often forgotten smaller Central and Eastern European countries are paving the way. So I wanted to maybe focus here and pay tribute to countries and places and communities that very often are under-recognized in advancing the use of technology and advancing technology in a responsible, humane, and evaluated fashion. Thank you.
Thank you very much. So I think we're getting to the end more or less of the panel because we have 8 minutes left. So if I don't see any question online, I think what the audience is completely captivated with you, because it's very interesting to hear every point of view, and I think this is the pathway or the value chain we're talking about, that everybody's really convinced. So I would like to ask you, just in conclusion, to really think where this is going. Because the title of the session is Cardiac Disease for a Better Care of Patients. So we've talked patients engagement, we talked technology. I know we could talk all afternoon long, and I would love that. But where do you see that things are going? Because you mentioned education, we mentioned pathway, we mentioned a good use of technology or responsible one. What is your take? Where do you think things are going? Because one of the key concerns, and I think we discussed this with the organization too today, is that there's a lot of talk in other, let's say, diseases. We had COVID, so infectious disease became the thing. Rare disease, fortunately, are becoming quite important, but it seems like non-communicable diseases, and sometimes cardiac one, well, it will come, you know? We don't really think about it, and the day comes, sometimes, as you said before, it's a little late, and then you realize you have to understand how your body works. So how can we convince people to, you know, be more aware of what's going on, and where do you see, I mean, I know it's a broad question, but just your last take on the conversation of today. So 1-2 minutes. Do you want to start? Doctor?
Okay, thank you.
Doctor? I mean, you're the one dealing with patients every day, so I would like to know.
I understand. I think if I have to conclude for my specialty and the others too, the patient have to be a partner. And if the patient is a partner, you have to live with him as a partner. So how he feels, what is his real question, and what the problem of the organ in that way, the heart, is in that body and in that human person. And if all the technology give me the tools, for me, doctors, to know rapidly and in confidence with, again, it's easy, but it is humanity, it's really simple in a visit to understand what is that person that I have in the front and how in 20 or 1/2 an hour I'm able to transform the relationship between a patient and a doctor in 2 partners. And that's it.
Thank you very much. Your take in a minute.
Yes. So I will follow the same idea. Yes, the patient need to be a partner, but in terms of management, we always say if you want to help people, you need to know you and to be in a good position to do it. There is a small film which named Lucille that we have made in our company, and this is a patient, and in the morning he has all the information, in fact, like when you are brushing your teeth, you can see how you are, if you have a concern. So if it's the case, you can have a quick appointment with your doctors. So perhaps to be your own partner. So to really be in a position where, in fact, as we said, before becoming a patient, just to have a conscious that you will be a patient. So really be in a position, in fact, in the future, to have all this data, and that these data are your own data and not the data of the doctors or not the data of the different company, and be in a position to really be an actor who will take this health in our hand, in fact, in the hand of the patient. And like this, if I took the last idea that we have, it will be certainly easier to face all the transformation that we need to have. So understand why we will have a new technology, why this pathway is working like this, what we can do differently, how we can act differently, and exchange, I will say, with all the communities.
Thank you very much. Your take, 1 minute.
I think we all agree here that it's the time where we are just healing, curing symptoms is over. Now the holistic approach of patient is now, let's say, the center of the practice, or we'll hope and fight for that. And I think the end of this discussion, I would like to enlarge this vision to the environment of the patient and also by considering the caregiver. I think it's also important to have a look of the caregiver, because we can see now that the caregiver will be the future patient because of the fact that caring for someone could have so much impact on your health, mental health, physical health. And I think it's also important at some point to discuss this, this part of the partnership. There's the patient, the clinician, and also at some point maybe the caregiver. And I think it's important to involve them also at some point.
Thank you very much. Vincent.
If you ask us where we are going, I think all of us, we are going to the same place at the end. And this should never be forgotten, because it's at the heart of humanity, I think, basically. And in my company, the motto is we are all patients, so that employees every day remember why they are getting up. They are getting up to serve their grandmother, their relatives, themselves, and the patient at the end. And we really need a very strong purpose that is really linked to this humanity, because innovation can be technical, it can be social, it can be whatever. We are very creative, human beings, but we should never forget that the patient is at the center, and we're here to serve the patient, I believe.
Thank you very much. Elie, your take, and then I'll pass it to Magdalena and we'll wrap up.
Maybe one idea I would like to add is that maybe thanks to innovation, one of the important changes is that it's possible to make more personalized medicine, more personalized treatment, but also more personalized prevention. And this is something very important. And I think also when you are saying more personalized, it has to adapt to the patient belief and to the patient capacity of accepting or not accepting certain things. And I think this is really something that's at the heart of what we're trying to do, to try to understand where is the limit of what some patients can accept and others would not accept. And thanks to all this technology and all the data that we are collecting when we are, for example, monitoring the patient, it's possible to provide more adaptability and so more personalization in the way the patient is taken care of.
Thank you very much. Magdalena, you're the last two. 1 minute.
There is a benefit in being the last one because I can echo quite a lot. So I echo quite a lot that has been said. And I would definitely like to emphasize the person-centered care. And I on purpose moved away from patient-centered to person-centered. And I would want to broaden this concept here is to say that what about finally pivoting and focusing on health prevention and health delivery rather than patient and disease. There is a lot of heart-related diseases that can be prevented. However, they're not. And so they take away the funds, the time, and the attention for people who really require focused health care a long time. So my call to all of us and the listeners would be, are we as a society ready to focus on innovation and technology for health and pivoting towards health? So those who have potentially those conditions that cannot be avoided or prevented get a better centered, person-centered care. That would be my take. Thank you.
Thank you so much, and I think that's an amazing conclusion. Thank you very much to all the panel for being here. And now I pass it back to Alison. Thank you.
Thank you very much, Anaïs. And thank you to all of the excellent speakers on this panel. It was truly an enlightening and inspiring conversation. We will be sending out our second survey right now to get your feedback on this roundtable. And our event is already drawing to a close, so we're going to be taking a very short break, 1.5 minutes to be exact, and at 3:50 we will be having the concluding word from Christian Policar. So stay with us, see you at 3:50.